बघायच्या आधी त्यांना फोन केला अपडेट केलं सुरू द्या
Check mic test. Check. Hello, check.
ये ओरिजिनल वैस्कुलर क्लब मीटिंग का मेनू कभी नहीं था, ये न्यू है। स्टेटस और स्टैंडर्ड मंथ आफ्टर मंथ, ईयर आफ्टर ईयर। कोहिनूर होटल, सिद्धिविनायक होटल, 6-7
Good evening, everyone. We'll be starting with the Mumbai Vascular Club meeting. I would request Dr. Raghuram Shekhar, President Vesomac, to kindly come and grace us.
So how many of us are here? Is good to start Vesomac meeting again. I think these meetings date back to more than 20 years ago when we used to hold it, including this venue. So I think we'll start off with the cases. Hopefully we'll make it a monthly. So those of you who have not brought their cases or have more cases, I think bring cases so that we can discuss it. We'll encourage more of our residents also to come so that they are encouraged to present cases here. So we practice how to present cases and then we can have discussion on that also. And this has been such a stimulus that many of my residents have attended this and then taken up vascular as a career and become vascular surgeons. So I think it's a good platform. I think Anirudh will present your first case and then we'll have discussion after that.
Thank you, sir. So I'll be presenting the first case. There's a case presentation, the dilemma of a splenic injury. So this is a 33-year-old male weighing about 150 kilograms. His basal BMI was about 54. He was involved in a road traffic accident where his bike collided with a pavement. And the initial presentation, when he came to us, there was a blunt trauma towards the left side of the chest with pain and tenderness. There was a fracture of the left wrist. The initial hemoglobin had gone down, and the CT findings were suggestive of a grade 3 to grade 4 splenic injury. There was hemodynamic stability after he was treated medically, and there was no further drop of the hemoglobin initially. The management hence from the general surgery side was for conservative management with close observation. On the subsequent course, the patient was discharged but readmitted within a few days with worsening of pain on the left side of the chest. There was a drop in hemoglobin observed, and this required blood transfusion. But despite the transfusion, the hemoglobin continued to drop, and because of which a vascular opinion was taken, we had advised for a repeat CT angiography, which showed doubling the size of a splenic hematoma. So, considering the hematoma increase, we planned for an angiographic embolization, first a DSA and an embolization, or the general surgery side had said you first do the DSA. If there is nothing, then we'll plan for a splenectomy, because that is what was indicated for a grade 4 spleen injury, splenic injury, based on the progression and the hemodynamic stability of the patient. So this is what the CT looked like. If you see the sagittal section, as we keep going down, you can see a lot of contrast in the middle of the spleen, and it suggests a grade 3 to grade 4 splenic injury. You can also see the place where he had the trauma. There is a lot of bruising and the splenic injury here. Now, looking at this, there was a definite increase in the size of the hematoma on the left, and the patient was symptomatic for the same. This is a coronal section of the same, where you can see the splenic injury and the hematoma as well. So I first had a right groin axis, went up, did an abdominal DSA, went into the celiac axis.
Okay, one sec. Let's stop here. What is the role of angiography looking at the CT picture like this? Who would advise what? Would you do a DSA in this case? What would be the indication for doing a DSA? What do you feel? Why would you want to do a DSA here?
So normally,
Why not go ahead and just remove the spleen? It's a huge hematoma there. It's involving the main body. It's grade 3, grade 4. I think grade 3, grade 4. I don't think there is a recommendation for conserving the spleen. Why not just go ahead and probably angio is meant for what?
So
Angio is meant for.
as per the American guidelines, grade 2 till grade 2 is conservative. Grade 3 you can angioembolize. Grade 4 and grade 5 you should do a splenectomy, because that is where there is complete laceration of the spleen. But the patient came to us after getting discharged, after being conservatively managed by the general surgeon, and the reason of doing an angio was to just make sure what is going wrong in the abdomen.
Maybe a CT would have been a less invasive way of.
This is
Yeah. So then why do you need an angio? That's what I want to know. Why at all do you require an angio?
Because the hemoglobin kept dropping even after giving blood, even after the CT. Because when one blood was given, the hemoglobin went from 80.
Yeah, exactly. So what I want to know is what you will achieve in terms of information from an angio which you wouldn't get from a CT scan.
Exactly why it will come next, sir.
Yeah.
Because as you see the angio, you will see that the angio has picked up more than what the CT has picked up in this case. So when we did an angio, the splenic artery, you can see over here, quite tortuous in nature. Thereafter, I cannulated inside and found a pseudoaneurysm inside the substance of the spleen. Now this pseudoaneurysm was not picked up on the CT. It showed a contrast blush, but when I recompared it to the CT later on, I could not even see the pseudoaneurysm. I can show the CT again. If you can compare the CT here, as we go down, here, so if you can see here now, You can see the hematoma, but there is no sign of a pseudoaneurysm in this area, because this is where on the DSA the pseudoaneurysm was located. Probably here, just where the splenic artery is, probably here it could be suggestive of it, but it was not reported even in the prior CT and the current CT.
Now, how will you differentiate between a pseudoaneurysm and a hematoma? Both will look same.
Both will look same, exactly. So thereafter, I cannulated inside. Now this was a catheter. It was a 5 French NBA catheter. I had to go, with 3 sheets. One was a long sheet. Then I took a guiding catheter and then a micro catheter. I went inside and cannulated as distal as possible. Now my dilemma in this patient was, the surgeon had told me do a complete splenic artery embolization. But this patient on angio, the splenic architecture was quite well maintained. The arteries were quite good. It was only this pseudoaneurysm which was a problem here. So first I thought, let me go and first treat the pseudoaneurysm, for which I did the coiling. This is a concerto coil. This is I think about a 9mm coil. This is a packing coil first, and after packing, I had actually covered the entire side of the pseudoaneurysm. Now I called up the general surgeon. I told him, see, this is the condition. So he told me that no, if you don't want to embolize the whole spleen, then just the segmental area where the pseudoaneurysm is there, just go and embolize it. So here I put PVA particles into that segmental branch, which was supplying the splenic hilum, and thereafter there was complete cessation of flow into that branch and the pseudoaneurysm sac without any contralateral filling into the same. I still was doubtful about.
That flush is still there. Aneurysm bleed is there.
But then I still had my doubt. I called up the general surgeon. I told him, see, this is the case. And he said that let us wait, we can keep the materials again and go in if required. Young chap, 33-year-old. Waited for about a week, nothing happened. Patient went home, and it's been a month on follow-up. Repeat CT also shows regression of the hematoma size, and we tried to conserve the spleen in this case.
Any infarct?
There were no infarcts. It was just a hematoma. There was no infarct visible even on the CT previous to that. For the embolization, that entire area was gone. Yes.
Sir, I think unless there is any hemodynamic instability, we should not go for DSA and DSA. Yes.
Unless there is any hemodynamic instability, we should continue conservative management. We can consider embolization only when patient is acutely deteriorating and surgery is too high risk for that patient.
The problem in this case was we gave blood, 2 bottles of blood. The hemoglobin did not budge. Next day, the hemoglobin fell by 1 gram. But yes, there was no blood pressure was stable, pulse was stable. Probably we didn't wait for the patient to go into a crisis.
Where was it? Bleeding into the spleen?
Into the spleen.
So the hematoma was increasing in size on serial CTs?
On serial CT, yes. It had doubled in size on the next CT. And the outcome per se, because it was stable, we didn't go to do
This is
anything.
how it is, means for splenic injury, how this is how we can conserve it. Means we have to just observe for hemodynamic stability.
Correct, but the guidelines are, this was a lacerated spleen.
Yeah, means this is like shattered spleen.
Shattered.
So this is for splenectomy then.
Yes, correct.
Yeah, that's what I'm saying.
Because this can cause abscess or I don't know, means what is remaining behind.
Correct. I completely agree. It is for splenectomy, but because it was not done in the first phase, the patient came back again. We did an embolization.
It's well encapsulated within the spleen. So down the time it should stop. Bleeding should stop on conservative
So
management.
is that pseudoaneurysm leaking or bleeding, or is it increasing? How does embolizing a pseudoaneurysm stabilize the hemoglobin? Was it an expanding kind of pseudoaneurysm?
Compared to the area where the contrast blush was, the pseudoaneurysm was located absolutely in that area, bang in the middle. and because of which it is just it could not be seen on the CT where the
But
pseudoaneurysm was.
that size pseudoaneurysm, is it large enough to cause a fall in hemoglobin? That's what is what are the chances that he stabilized because he is just conserved and a bit lucky?
Sir,
How much would you attribute your coiling of the pseudoaneurysm to the stabilization of the patient? It doesn't appear to be leaking or bleeding or anything. It's probably a chance finding. In a trauma, you do get pseudoaneurysm.
Whether the time to
but sir, rest.
Whether that coiling of that pseudoaneurysm has actually stabilized the patient and allowed the bleed to be conserved,
time.
or whether it's just that is what I want to know.
It was a drastic change from the time we coiled. So the moment we coiled, the hemoglobin just increased.
So you feel that pseudoaneurysm was actually increasing in size, or it was a...
It was causing the bleed, which was increasing the size of the hematoma. Because per se we did not know there was a
So when you did the angio, it doesn't show a leak outside, right? It shows
a flush.
the pseudoaneurysm doesn't seem to be leaking.
Yes. But is it, normally sir, with a pseudoaneurysm we can't leave it like that.
What would you do?
I think considering that he's gone home and he's come back, the better option is just obviously not.
Okay. Okay.
Not working, and anyway he's a huge 150 kg guy.
I think that is one of the reasons why this bleed was not knocked off in the first place.
I mean, it is much easier to do open surgery than going through that drawing also must have been a challenge.
Would there be any sense in embolizing the whole spleen?
But again, then the risk of splenic infarct, abscess,
It's very
all
stormy.
those sections, it is not worth it.
Post total embolization is a very stormy thing. It just allows you to buy time for you to do it.
Exactly.
When the patient is unstable, you embolize the main artery, stabilize, but eventually you will need to knock off the spleen. Otherwise, what he said, abscess and all that.
Okay.
It's quite a stormy period.
I mean, this is the main thing is that you don't know how he will behave after that.
Correct.
And the fact that he's bled and he's dropping hemoglobin, that would suggest that it's better to get. I mean, you don't lose much, but if he gets a problem, then it becomes a much bigger issue.
Okay. That's it from my side.
Great, thanks.
Thank you, sir.
Next, Piyush.
Next is Piyush.
Good evening, everyone. So my topic today is about carotid. A couple of cases I'll try to see if we can finish. So first is a 75-year-old male patient who is hypertensive, non-diabetic and hypothyroid. He's overall very fit, goes to gym, does everything. He came to me with a question whether he needs a stent or an endarterectomy in the first place. The back history is that 1 year back he had some right-sided hemiparesis. So right upper limb had some weakness which just lasted for a day or so and then it disappeared.
Can I ask a question? You said right hemiparesis and right side stenosis. So it should be.
No, that is right. So he recovered completely and he came with a Doppler which was a follow-up Doppler. The first Doppler he lost. The follow-up Doppler came. There is right-sided 95% stenosis compared to the original one. It is the same, and the neurologist has written right ICA stenting. I said first thing he asked. Okay, so first thing was about the surgery and everything. I said, see, if anything needs, you need endarterectomy, not stenting. That is the procedure. Which side, what, how, we'll discuss later. But first, let's get an MRI. So it got an MRI angio. Because the Doppler, again, he would go to the same guy who would do something similar. I said, let's get a different modality. So got an MR angio. which was like this. So he has, so the image is inverted. That is that's the left, and this is the right. This is from the posterior view because the image that I had didn't show it properly. So the left side has a tight stenosis. The right side has even worse, which is so that's the right, which has 95% stenosis, and that's the left, which also is severe. Second, the vertebral left side is hypoplastic, right side you can see a good vertebral going. So now we have a patient who's got right side issue, which is the left, which is the index, left ICA, which is the index. The right is even bad on the imaging bit, but asymptomatic from that point of view. So
Why did you opt for an MR angio? Any reason? You opted for an MR angio, not a CT angio.
Nothing specific. Generally, I prefer MR if I can get if the calcium is less, so I can see what is going on.
So when he had his stroke 1 year ago, it must have been an MRI done that time, right?
Yes, but I didn't have. He didn't get it with him. So I don't have a baseline what was going on then, which was in Apollo. But in spite of that, I couldn't find because he said they are not there. So at present, this is 1 year post his neurological event. Right was the index right from hemiparesis point of view.
Stroke was managed by a neurologist.
Neurologist, medication, conservative. So now he is come asking whether he should do this right-sided stenting or endarterectomy. The MRI has shown both sides severe. Left becomes symptomatic, but then there is a question whether, because the event was a year back, now this becomes more like very long time. All the studies that we talk about, we are looking at 6 months time when we.
What medication was he on when he came to you?
Dual antiplatelet.
Aspirin, clopidogrel.
Aspirin, clopidogrel and statin. So, spoke to a few more people just to discuss the whole case, and I decided to do a left endarterectomy, which went fine. This is the second image, which shows the left was the. So there is one more thing to add in the MR angio. The right side, although it was 95%, above there were tandem lesions, multiple ones of them, in the intracranial region.
So that is not seen. You don't have images of that.
No, sir. Not. I couldn't. I mean, I looked, went through all those, but couldn't really. The MR. I'm not very good at MR to go through. So the left is hypoplastic. The right is the one which is dominant or has very good flow. I think it is shown in this.
You have a pointer.
So this is the vertical. The right side which is dominant. The left side you would see a small faint line.
Piyush,
Yes, sir.
the reason I asked you about CT angio
Yes,
is
sir.
because you're planning surgery. I didn't see you. You didn't repeat the carotid doctor because you had a bad report from before. I like to see what is the level of the bifurcation, what is the extent of the disease, because it makes your life easier because you know whether it's a low bifurcation, high bifurcation, what is the relation of the angle of the mandible. So that information is a little difficult to get with the MR angio. So my preference is to do CT angio unless there is heavily calcified this, in which case then it becomes difficult to see on CT.
So when he came for pre-operative checkup in the hospital, so I had done a Doppler myself. So there is that I do only as a screening Doppler. So I don't get a report of it, or I don't save images. But I saw is that the bifurcation was not very high. So those things I took care of. So I was pretty happy with that. Screening Doppler, because I can't charge the patient, I can't give a formal report. So that's why the images are not with me. And so then I did a endarterectomy, used the fluorinaration. It was pretty straightforward. Patient is doing well. So in this case, mainly my discussion revolved around the fact that would we call this as asymptomatic now that a year has gone, and what we would do with the right side, which is 95% still there.
So what is the current data say regarding treatment of asymptomatic?
So the ACST2 which came said it is still
Only
not
in trial.
advisable. Huh?
Only in trial scenario.
Yeah, trial scenario. Not it is not. So
It's not advisable, but I see a lot of asymptomatic carotids getting stented.
I really, it's not typically symptomatic, but neither is it asymptomatic. And it's a matter of time before he gets another event. I mean, that's what your NASIC and all those studies show. So under those circumstances, when you have somebody who's had a stroke, somebody who's had critical stenosis, I don't see any point in treating it like an asymptomatic. I think because it's known 3 times the risk of conservative management.
So would you do the left or the right now?
Left first, and then right.
and then the right.
Right also, no? Because if you have 95%, right is also 95%.
But right is the truly asymptomatic. The left is a symptomatic asymptomatic.
So left you did.
So how do you choose then?
No, you do left first.
Yes, you do only left.
Because I presume he's a right-handed person. So left becomes the dominant circulation. He's already had a stroke there, and out of 4 vessels, 3 are almost gone.
Yeah.
There's only 1 vertebral that is supplying. If this guy ever has a drop in pressure, he's going to have a watershed infarct. He will have emboli. So under those circumstances, it makes sense to treat the left side first, since it was symptomatic once upon a time, it's a dominant hemisphere, and it is critically stenosed. It makes sense to go ahead and treat it first. And then if he handles it well, there are no other risk factors, then one should consider doing the right side later on. What any investigation you will do before you do the right side? Which normally we don't do.
But I'm thinking of not doing the right side.
Fair enough. Assuming that, so you have 2 options: do it, not to do it. Assuming you are doing it, what would you do? One test.
Transcranial muscle.
No, why? Something very simple.
Doppler gradient.
Something else. Something not imaging related. I like to do an ideal indirect laryngoscopy, because you operated on one side. By chance, if there is some vocal cord palsy or this, and you do this side and that gets affected, the guy will end up with a stridor.
So in Vedanta, when we used to do, so all carotid surgery we used to do ideal.
Do you believe in the dictum that after 3 months of a stroke, the medical management stroke risk versus surgical stroke risk remains the same?
So there's the ACST data, and if you look at those guidelines of European Society, they have given many boxes basically describing all these timelines as to, they have basically stratified into different groups as with timelines, with percentage of stenosis, with gender, and they have made those boxes which tells you if you are so much time into your from the primary event, the benefit starts going down. So it is 3 months for males, it is probably a month only in females. So in females, the effect of surgery or the benefit of surgery goes down much faster. In men, it goes a bit more. For critical stenosis, it is the benefit is obviously more. For severe stenosis, which is 70 to 90, critical is more than 90. So again, with 70 to 90, the benefit moves. So it is like that. The lesser the stenosis, females, the risk starts going down.
I think in hindsight, since the surgery went off well, it's a job well done. had you had a complication, we would have discussed saying why did you do it.
Neurologist must have know the.
No, if honestly, I mean, it's a dicey situation. If you go by strictly by the the crest and all that, and when you actually derive proper benefit, how soon after the index event you should do it. If you go by that, then probably you just do a conservative management. However, as he said, practically you can trial data apni jagah, but real world scenarios, you see these guy will land up eventually. So in hindsight, if you say, I think probably you did the right thing. But had you had a complication, probably there would have been a lot to discuss. Had he gone to somebody else, a neurologist or somebody who would have told you, data doesn't support this, why did you get it done? So it's a tricky situation.
Even bigger than that, is everybody writing right side 95%, and they would have started saying, why the hell is he not doing more, which is 95, and you are looking at something which is less than 95. So that was a dilemma. See, the second was this whole thing that
because
how much was less than?
Nobody
you've not mentioned anywhere.
So the MRI mentioned it as moderate to severe. And the Doppler. So there is the Doppler ICA velocity was 315. So it is
The right or left?
For the left. The right is high. Right was about 380 something.
So almost same, no? 388 is 370, not whatever.
17 and so, but that
70%.
and what made me more worried was the right. If you see, there are more lesions up. So even if I put a stent or try to do something funny, if something from there goes up, it becomes a bigger problem.
Do you guys get to see a lot of carotid, asymptomatic carotids being stented? I see hell of a lot. I see it almost one a week. No medical management.
They come to you for what, sir? Already stented?
No, I see it because I am sitting in the console waiting for my case and I see a carotid being stented. I see it being stented. Yeah, and I see that. And the neurologists don't seem to believe, or they don't want to accept. Asymptomatic carotids still get referred for treatment to the neurointervention on a regular basis. And 60% asymptomatic still getting stented.
So when I did this case, the OT, the mama who was there in the OT, got me the next patient in next 5 days. He had got the record of neurosurgeon was going to put 2 stents in both sides. Again, this was left side symptomatic, both sides moderate, but this was little more, you can see. So I did his left endarterectomy and nothing on the right medical management. Because he saw me doing that, he said, I've got a patient. And the neurosurgeon who does this very frequently was going to put both side stents.
Same time?
Same time, 4.5 lakh budget.
Same time both stents?
Same time both stents.
The thing is, if you're, as I said, if you're good at your job and there's no complication, then everything is acceptable, right? You see, in my hands, stroke is less than 1%. So it justifies the procedure. As simple as that.
It's always that way if you do unindicated case.
Okay, so the next one is carotid dissection. So this is something which has been bothering me for couple of years now. Every now and then there is a patient who comes with carotid dissection, somebody is ready to put a stent, and then they come for a second opinion. Problem is, we as vascular surgeons are not the primary neurologist. The neurologist that I call around in Navi Mumbai or somebody in Bombay or in Maharashtra, they tell me, हाँ stent है तो वो dissection तो stent डालने का नहीं तो stroke हो जाएगा. But data is something else. So I will just talk about it. So this is a friend's relative who came, 44 male, non-smoker, Guju guy, no comorbidities. He had right side neck pain, slight slurring of speech, which recovered in no time. It was recent onset. He had high blood pressure, which got controlled. He came to me a month after the primary problem, the primary diagnosis, and he already had a DSA and a Doppler showed dissection. DSA done. They said we have to put a stent. but they were not ready, so they started shopping around and reached me. That's the DSA. I mean, that's not even a DSA, there's just a cine. So the whole CD has only cine done by a neurosurgeon, which showed dissection. I'm not sure if it's a very good quality thing, but this is the another one. So I spoke to a few of my friends in UK, Canada, and neurologists, and so they said, "Nahi, the data shows you medical management. It's not really stenting for everybody." So after speaking to many people, I said, "Fine." The friend who was involved, I said, "See, if you believe what I have understood from many people is we'll go with medical management. Right now he is not having any issue. There's no symptom, there's no sign." So we gave him 6 months of dual antiplatelet therapy, and 6 months Doppler was normal. So all the carotid issues healed completely.
No solution.
Nothing. So when this happened, I started talking to friends to ask about, okay, what is your evidence? Because at the end, I have to speak to somebody and say, okay, why am I saying no stent? So came two couple of papers. One was from JBS, the other was from JAMA, which says outcomes of carotid artery stenting from dissection, and all the data, if you just try to go around it, says it really doesn't help.
Stenting
Doesn't help. Although if I speak to all the neurologists around this area, or at least in Navi Mumbai, I'm pretty sure everybody said stent.
You know, this patient came in a chronic state.
He came a month from the first, and he had this slurring of speech.
So what was the cause for the dissection?
Hypertension, sir. So undiagnosed hypertension.
I thought hypertension was after or before.
So this
You are not a known hypertension.
Not a known hypertension. So this was the primary event where hypertension was diagnosed.
In an acute setup, if it comes,
Sorry?
it comes immediately.
Still medical management. So there is a trial called CADIS. Initially when everybody started stenting, the CADIS trial which came showed many patients, and that defined that antiplatelet or anticoagulation is enough. You don't really need a stent in
Sir, this
carotid
was
dissection.
told to me also when I got a stroke now. Same way they told it is only antiplatelets for 2 years at least, and this will be some dissection, and this after 2 years if you do any MRI or this, that dissection won't be seen.
His work.
मैंने किया नहीं MRI.
ये है ना, ये तो अच्छा है, काम करते हैं. बहुत तेज हो गया.
Piyush, paper there it is an antiplatelet therapy versus anticoagulation therapy.
Yeah.
So which one is the better? Stent, definitely no stent.
Yeah.
So which one is the better?
No difference.
No.
No difference. Yeah. Sorry, I haven't got the whole paper, but it's with me. If you just put CADIS, you will get the outline of it. No difference.
So this medical management was aspirin clopidogrel or what was it?
Aspirin clopidogrel
Aspirin clopidogrel.
versus I think that the other one was warfarin. There's a neurologist who is in UK who was from here only. So when I was there, I used to talk to him. So I called him up, and he said the same thing, that we follow this. Then there is a neurologist who's in Jaslok who was in Canada. I called her, she gave me this reference of this paper, and she said, this is what you should be following. But when I talk to people around, I think they are so primed that you should put a stent, otherwise this is going to happen. So there's a lot of scaremongering. And as Sir said, he sits in console and sees people getting stented. I have the same thing. I sit there and I look at stents being.
So what's your next course of action after this case?
For
What will you do?
in this patient?
What will you do? Not this patient or that patient or this. What is your next course of action?
Nothing, sir.
Share these papers with the neurologist.
So then so so there is another thing.
They don't take it very.
One day my
You have nothing to lose, right? Anyway, he's not sending you cases. At least from zero, he can only go up, right?
Yeah,
Not
so,
to the bottom.
so I tried catching up a few people to explain to them about, so the person who wanted the stent on the right side, 95%, I told her about that. She's not interested because there's an IR who gives, again, the same story. Now one day my receptionist in the clinic came, that her father has got a stroke, he's in KDA, Koperkirna, and he's got 95%. She just showed me that picture. I said, do you do this carotid thing, sir? I said, yeah. So I went and spoke to the neurologist. This guy developed right side complete hemiplegia. I told him, this is the guidelines say you shouldn't be intervening now. What benefit are you going to give? And more importantly, it can convert to a hemorrhagic stroke. The next thing is, they put in a stent. In spite of talking to the neurosurgeon who did it, in spite of talking to the neurologist, nothing. They don't care.
You get a hemorrhagic stroke and a neurosurgeon then opens the skull and evacuates the hematoma. The usual story that I see all the time. So basically, it's a win-win for everyone except the patient.
I think share the papers. That's a nicer way of doing things. And like you said, you don't lose anything.
If no questions, thanks Dr. Piyush.
Good.
We next go to Dr. Vineet Paliwal.
आज क्या होता है 8 बज गए
So my case is bilateral in young girl. So 24-year-old female came with complaints of bilateral lower limb swelling and pain since last 2 days. Vitally stable, no breathlessness. Venous Doppler showed bilateral iliofemoral popliteal proximal DVT. Rest all investigation within normal limit. So on history taking, I asked, because this was extensive bilateral, so I asked any significant relevant history. So she told me, so I asked, are you on rest? So she said, I had back pain, so they were treating for spondylitis, so asked me for have some rest, but she was not on bed rest. With respect to menses, she is having dysmenorrhea, menorrhagia, and on and off lower limb swelling and pain on long standing. So when I asked, so this swelling since how many days you have? So she said 50% of this swelling is I have every time. This is so that goes on resting and comes back on long standing. But this is recently increased, so I came to hospital. So
wait. Patient obese.
Not very obese, around 70-80 kg.
And back pain, right?
She has back pain. She was having back pain and dysmenorrhea, menorrhagia, and lower limb swelling.
Was she on hormones?
No.
Any hormone manipulation?
No. So I did ask for CT pulmonary angio with DVT protocol. So on pulmonary angio, there is a P, subsegmental P, but it was chronic, recanalized, partially recanalized P. And here you can see dilated azygous vein. So dilated azygous vein, and there is intrahepatic IVC was present. After that, there is both azygous and azygous system was dilated, and there is no infrahepatic or after renal there was no IVC. So it is like cord like, or there was no IVC at all. And till confluence there was no IVC, and at confluence both iliac veins were meeting each other, and below that both iliac veins were thrombosed. So here you can see confluence is there, both iliac veins are getting separated. And there were means only dilated azygous and hemiazygous system, but not much collaterals. You can see here. So delayed thin images also I saw, but there was no any signs or symptoms. Means,
Has she taken any Ayurvedic medicine or
no,
any
no, sir. She
weight
was-
loss therapy
no,
or
no.
anything?
Well-educated family. She was MBA student.
Yeah, the well-educated are the ones who take.
But
I've
unfortunately,
seen,
she
I've seen
didn't
3
go
or
there.
4 of these similar ones, right, where CT shows just typically like this, old pulmonary embolism, bilateral DVT, and IVC after a certain point is just cord-like. And there are lots of collaterals.
So here we could not see cord also. Means I was not sure is there agenesis of IVC or it is chronically thrombosed. So for next 48 hours I tried conservative.
It can't be agenesis because you've had an old pulmonary embolism.
So that's what.
Clot has come from somewhere.
So that's what discussion is all about. So I waited for 48 hours because I told them that if in normal DVT we do clear with this pharmacomechanical thrombectomy and all our newer interventions, but there is outflow, so that can be kept patent and you will get good result with that. But for her, I told let's see conservative management try for 48 hours, but pain was still persistent, swelling, extensive swelling was there, no improvement. So I explained to them we can do something like pharmacomechanical thrombectomy plus CDT, just like debulking. Means we can bring her back to her pre-symptomatic stage. That was my plan. So bilateral popliteal vein access were made, and
Yeah, but if you have a correlate, if you cannot see the IVC, correlate.
yes, sir.
So why?
So that's what. But she
Symptomatic improvement.
Yes, means like debulking. Means whatever.
At least
thrombus
you
we can-
reduce the symptoms if you remove the clots.
We can
there.
bring her back to her pre-hospitalization state. So that was the plan, and well explained to the family. This might not give complete relief. So they were agreeable, and we proceeded with the plan. Pharmacomechanical thrombectomy plus CDT. CDT to just continue whatever the means after the mechanical thrombectomy will remove the most of the burden, and CDT to keep open the collaterals whatever they are. So both venogram right left complete thrombosis of popliteal. So she was very anxious. So I did puncture in prone position on bed, and then make her supine, kept her supine on table. So sometimes I do like that on bed, like under ultrasound guidance, so puncture on in prone position and make her supine later.
So how do you sepsis already?
Repainting.
Repainting again. So just put tagadam on that sheet, keep it sterile.
In venous, normally you need to upgrade the sheet. So what sheet do you
Yes,
use
6
primarily
French.
function?
No, 6 French.
If you want to use a 8 French MPA for suction or 9
No,
French.
no, no. So I upgraded it later on.
Achha, then again change the sheet.
So
and-
you put in wire, over the wire you can upgrade to anything.
Okay.
So this is right left venogram both showing DVT as usual. So this is at pelvic venogram. So there is some collaterals, complete occlusion of iliacs both sides. So interestingly here both wires were going here and there very easily, which we find difficult in venous cases. So I did leisurely I did thrombectomy both from right to left to right.
Using what?
This is angiojet.
So and because her IVC was not there, means renal vein I was not sure where it is draining, so use minimum contrast because she underwent CT pulmonary angio and again this procedure again. So
Ice only.
so minimal contrast, so this runs are not that visible, but there was no holding of contrast. So after angiojet suction, there was good draining veins were there, and so this is iliac venogram. So the almost 80-90% thrombus were cleared. So it was slow flow, but there was no stagnation. So now question comes, so after that on next day her swelling came down by 30-40%. On discharge it was like 50-60% swelling were reduced, and she was pain free and better than before.
Did you also give thrombolysis?
No sir, so I was planning to give continuous thrombolysis, but same day she started her menses, so I have to change that plan.
Some thrombolysis was already gone with
Yes, 15. Yeah, that by doing angiojet, but I could not continue further. And that was in like local area, it is not, yeah. So this is, so what it is, I don't know, means IBC agenesis.
When you cleared this, the legs, did you find it was acute or chronic? Was there some
No,
chronic?
sir, no.
Purely acute? Purely
Acute.
acute.
So most of the 80-90% were cleared. And it was almost we finished 400 seconds, so I could not do it more. Otherwise, it would have been 100% clearance like we've seen unilateral DVTs.
But Vinny, wouldn't thrombolysis help in opening up the venous channels on
But
top?
she started her menses, and she told me before only that it's heavy menses every day. So she used to bleed like for 3 to 5 days heavy.
So probably stop the let the menses get over.
So since 48 hours we were trying conservatively, but pain was not reducing, and that's why we took decision of doing something.
You do DDI?
Huh?
You check?
I don't do diagnosis. I don't know the significance. Maybe for follow-up we can see how the D-dimeris is getting downtrending or uptrending, but for activity or for routine I don't do D-dimeris.
Vinith, how was she symptomatically after procedure?
Yeah, so she got relieved, her symptoms got relieved, and swelling was reduced by around 40% by next day, and on discharge around it reduced by 60%.
And one more thing, she had that dysmenorrhea, amenorrhea. Was it due to pelvic congestion or something like that? Any correlation?
So that's the question. So I'll come to that in our discussion. So IBC agenesis is one of the uncommon anomalies of IBC. Prevalence is around 0.0005% to 1%. So this is around 1 to 5% in diagnosed DVT. But in undiagnosed DVT it is 0.005 to 1%. So types of agenesis are like suprarenal IBC, absence of infrarenal IBC or entire IBC. So I went through some literature. So there are two terminologies, IBC atresia and IBC agenesis. So both are used interchangeably. So it's very difficult to differentiate between them.
Sometimes you have a butt cherry which encroaches onto the IBC.
Yes, sir, but she is having an intrahepatic IBC
So I
patent.
don't think this is an atresia at all, because you had a pulmonary embolism. Where will that clot come from? At some point in time, the IBC must have been treated.
So that's the definition, sir. Atresia and agenesis. So IBC agenesis implies to developmental failure. Means IBC develops from subcardinal, supracardinal, and posterior cardinal veins at suprarenal, renal, and infrarenal level. So if there is any developmental anomaly, then this can cause agenesis. Means it's not there at all.
All that I understand, but where did your pulmonary clots come from?
Yes, sir. So in IBC atresia, it results from prenatal insult. So IBC was there, but because of some infection, it got thrombus or atretic or fibrotic. So that is the difference between agenesis and atresia. So that's what I wanted to discuss, is what it is, agenesis or atresia. So that's why I have specially mentioned that there was a old PE but recanalized. So from where it came from. And so in both, why we want to differentiate? Because endovascular reconstruction is feasible in atresia, but it is almost impossible in agenesis. So there is a prognostic value for this.
Yeah, but having said that, I think it is best that young patient, she's 27 or 29 or whatever.
24 years.
Yeah, so with no PTS features, conservative, IBC reconstruction and all this is more meant for those who have severe PTS. So with just a leg edema which symptoms are reduced,
So,
at 29 doing a reconstruction IVC with stents,
Yeah.
the long-term patencies are not good. So
yes, sir. So
Yeah.
I have some questions for you.
yeah.
So unanswered questions for us, all of us. So impact of this condition on her career, because she is an MBA student chosen marketing as her career. So I told, please change your career because you are not into that career right now. So find good.
No, I tell you, in young patients, the recanalization is so good with long-term anticoagulant. I have 3-4 patients like this, where after doing the angio, we got this kind of surprise because the CT said we can't see. I thought maybe because obese patient, bowel gas, whatever, or maybe chronic thrombus. But we put them on anticoagulant.
Yes.
Young patients, they resolve very well, and with all collaterals and everything, they are back. There are no symptoms. There are no symptoms.
So that's why past history, which I have mentioned for a few points, she is having dysmenorrhea, back pain, menorrhagia.
Maybe that's because the collaterals are there, so she's having some kind of pelvic congestion because of that.
Yeah.
Because of the collaterals.
Yes, so that should have been picked up earlier, or we should have kept high
Possibly.
index of suspicion.
Yes.
And means, so next question is should we attempt IVC reconstruction or
No. IVC reconstruction, iliac vein reconstruction, all these are meant for PTS. What you call 4B, 5, 6, that kind of CVI. Not for just acute
So
conditions.
any other non-invasive option? Yes, definitely anticoagulation lifelong.
Lifelong anticoagulation.
But like lymphedema pumps or something, stockings will help.
Okay, that comes to that comes to the question of stockings. There is diminishing evidence that
Yes.
stockings actually reduce the PTS,
Yes.
right? So, but in
they-
future probably the stocking guys are going to have to look for
So-
other ways of.
So
business.
more than PTS, sir, it is for symptomatic relief. Stockings are for.
Yeah, I mean symptomatic relief okay, but I think PTS is what we are worried about.
Yeah, class. I think.
Stockings, at least they help in reducing swelling.
Swelling and symptomatic relief better.
Yeah, but
Some patients complain of more pain.
Some patient complains of everything.
what we are worried about is PTS, right?
So some doctors also.
I mean, even post-thrombotic aggravative, but then they do develop long-term symptoms, ulcers, pigmentations.
But no, they will develop. But does stocking help to prevent that? That is the question. They will. PTS will happen in a significant number.
How do you prove or disprove that?
There's some evidence.
That means that we should not give stockings or we should give stockings.
You will give stockings. Even whatever the evidence is, you will give stockings. Because now it's a habit for you.
There's a Cochrane review which clearly says the major benefit of stockings is to decrease the pain and the discomfort more than anything else.
Yes.
But it also doesn't say that it doesn't help at all. So it is not zero effect, but
I think it is
something
2C
better
or
than
something. Yeah.
Nice guidelines have knocked off stockings. Nice guidelines. They have
I
removed
think
stockings.
the issue is really who has contributed to those guidelines. That plays the major role because we see too many patients who are not being given proper stockings and they have swelling, segment, pig, and they do so well with stockings.
No, so symptomatically, yes, they reduce symptomatically.
That's
But whether they
important.
prevent PTS is the question. So stockings are not meant for long term.
The AHA guidelines till a few years back was 2C recommendation
Yes,
for 2 years.
yes.
Stockings for 2 years helps in.
No, it's all changing, man. Now the number of papers that have come out, that I'll share with you in the group. There are lots of papers, lots of literature. In fact, I just come back from Viacom. There's a wonderful talk by Alan Davis. He's a big name in Venus Davis, a very academic person. So the general feeling in the UK is, and as I said, nice guidelines have removed mandatory stockings long term. Acute, okay, as you said, symptomatic relief, swelling. Long term, whether we used to say 2 years. How long to wait 2 years? There's no evidence for 2 years. That 2 years will help you to reduce the PTS. PTS pathophysiology is something else. So it's not related to your wearing stockings or not.
So there are a lot of things associated with stocking service. They have to change the method of wearing stockings and.
All that is there. But see, acute settings, we prescribe stockings for everyone, right? Acute setting, yes. Long term, patients are और कितने दिन पहनना है? We say 2 साल पहनना है. There is no proof for 2 साल anymore. That's my contention. Because we say long term to prevent PTS. But now they say there is no evidence that it prevents.
My take was not to take a time period. There's nothing magic about 2 years, 5 years, or 6 months. Ultimately, it's when they have to reassess and then you take a call. So at least I follow by checking with the doctor and symptoms.
This logic behind there is no side effect of wearing stockings, so I think
there is
a lot of side effects, financial and other side effects.
I find it difficult, especially.
You need 3 pairs. If you wear it properly, you need on an average 3 pairs a year. Right? You need on average 3 pairs a year, and the kind of Malat Kanjivili Borivili, the women. A lot of ladies having to work in wet areas, kitchen work, household work, keeping it clean, hot climate. Compliance is extremely poor. And whatever you tell them, they don't wear it. Elderly again is another issue.
So last and most important question, sir. If this we would have been diagnosed before in this episode, means before this DVT or any kind of VT, so what would have been management? Means still lifelong anticoagulation. Means if you see patient with there is no IVC and she is asymptomatic she or he is asymptomatic at the present. So what we can recommend?
No clot, no anticoagulation.
Probably antiplatelet, because she is having that history of menorrhagia.
But antiplatelet really has no clot. You are talking in terms of clot management, prevention of clots or symptoms?
No, means anything. What advice or how you would have been treated her like?
If this was a chance finding,
This was an incidental
suppose
finding.
this was incidental finding.
Without
DVT.
Without VT episode.
Just some swelling.
If there's swelling, maybe stockings, yeah.
And the activity, hydration.
Hydration, weight loss, increased physical activity, increased venous return, that's all. Yeah.
Prophylactic prophylaxis.
Okay.
Thank you.
Thanks. Okay. Our next case is by Dr. Ritesh Gaikwad.
अरे नहीं है, वो तो बोल तो रहा हूँ, इसमें पैसा नहीं है।
Hello, good evening everyone. Today I am going to present a case of aggressive atherosclerotic disease in uncontrolled diabetes with minimal options. So this is a case capsule. She is 66 years old female, known case of diabetes uncontrolled with hypertension. This diabetes was controlled by her, was treated by herself. She underwent right below knee amputation. IVL was done in 2024 March. And after that, she was following with me for the other leg and wound over the amputation stump. Now she presented with me the opposite leg with rest pain and discoloration in 15 days. Before this, she went elsewhere and had a left SFA populated ATA plasty in November 24. Just in a matter of 3 times, her disease recurred back. This was a PVR studies which shows AVF 0.7 with absolutely no or minimal flow to the toes left side, and TCPO was 20. then we did a DSA which showed around 40 to 50% stenosis in the idea with diffusely narrowed SFA and recurrent stenosis of the distal SFA and the popliteal. Further, below the angiogram, above the femoral and popliteal with diffusely disease reduced to a thin thread-like, and ATA was the only outflow with multiple stenosis, and in the foot, multiple stenosis in the ATA, and in the foot there was abrupt cutoff of dorsalis pedis with formation of narrowed plantar arch with the collaterals was the only flow. What we have planned from here. One question I had in mind was she just recurred back just within 3 months of her previous plastic with the drug-eluting balloon. So my plan was here for atherectomy, but she just take 360, but they refused. So we decided her vein was good. So we decided vein, right-sided great saphenous vein was good. We decided for Fred ATA, proximal ATA bypass.
Atherectomy of what were you planning?
It's a popliteal and
the popliteal and
back.
popliteal and SFA.
The popliteal SFA. But then you don't have a distal, you don't see a trifurcation.
Trifurcation is there, but it is very thin, reduced.
Second run.
Where was the IVL done?
Gujarat, Surat, Ahmedabad.
Which artery?
Vascular.
No, which artery?
This both SFA and popliteal same ATA plastic.
Same segment.
No, IVL was done 1 year
The right
for the
side.
Opposite.
Which is no amputate.
Below the
No
amputate.
amputate.
So we decided for left-sided Feb ATA bypass from common femoral to Feb ATA and immediately take her to the cath lab with the distal plastic. First we explored anterior artery, which was calcified but was in good caliber. Then we explored left great saphenous vein, narrowed in the distal part with multiple branches, but still good in proximal part. Then CFA had a descalcification at the bifurcation. We proceeded with bypass. Then post bypass there were no signal distally. So we hurriedly closed her immediately, took her into the cath lab as planned.
Your distal, where was the distal operated?
Anastomosis proximity. We did, and this was the first angio to the sheath. We showed no graft, but the patent native femoral and profunda were patent.
So graft is operated?
Yes.
Graft is
On table?
Not on table. I will come to that, sir. And this is below knee. And this we tried to cross the lesion distal to the anastomosis. These are the clips where the distal ATA anastomosis was done. After multiple attempts, we were able to pass into the distal ATA.
This you came from the native vessel?
Opposite.
Native vessel or the
Native
graft?
vessel. Because we could not see the graph, that's why we have to come to the native vessel.
What was your approach for access to the ATA?
Contralateral side through the native
For
femoral.
the surgery? Bypass?
Lateral.
Lateral.
Through the interosseous membrane into the proximal ATA.
Anatomic.
Yeah.
You went through the interosseous into the ATA.
Yeah.
Anatomic.
Anatomic. So we managed to cross the anastomotic side.
How it
First-
anastomotic?
Yes, sir.
No, no, they खाते distal anastomosis.
Okay, but if you are not in the graft, how will you cross the
Through the natives,
anastomosis?
through the natives.
I understand, but that means the graft has gone.
No, sir, I will just come to it. Just give me. Then first we took a distal angio of the foot to see if any plantar which is not thrombosed up. Yes. Then we plastered throughout the ATA, anastomosis as well as distal popliteal. This is distal ATA, mid ATA. There were very tight lesions. This is across the anastomosis. This is across the anastomosis.
Anastomosis was proximal ATA, right?
Yeah. Then post that we took a sheath angio, and we were till now hoping that graft is thrombosed. But post sheath angio, which was contralateral Balkan sheath, showed patent graft. This is the graft which is filling into the ATA.
Then first one,
Sir, so now here you can see three. This is an AT profunda. This is
So why you are not seeing it before?
so because of distal occlusion, there was no flow in this thing. So this is the graft. Because there was a distal stenosis just after the graft.
anastomosis.
And these are the distal
Outflow नहीं था.
angio. This is our ATA. This is it. The only thing the ATA was abruptly cut off. And proximally we stented with balloon mounted stent.
Post-
I had 50%. We have to keep the inflow going on because this was the second time she was.
Ulcer was
No, she was rest pain and discolorations.
discontinued.
It was a dependent rubber type. And post-op, there were good signal. She had a hypotension because prolonged surgery and epidural anesthesia. Pain decreased. She is now on anticoagulation. 2 cycles of bile blending were given. But still now she has first and second toe slight discoloration with pain. The rest pain which is managed on pregabalin and this thing.
So what is the take? Why is it
Also because in proximal DSA, like before that DSA, we just did anastomosis just proximal to the stenosis of the ATA. This is true.
Sir, because you were planning for outflow disease previously only,
Yes.
before the bypass.
Fed ATA bypass, taken to the catheter conduct.
So you should have done rather than first opening the outflow.
Repairing जाएगा full dose.
Plan.
नहीं, you can't do plastic. It will get occluded.
प्लास्टिक करके फिर bypass कैसे करेंगे? प्लास्टिक करके bypass बोल रहा है.
वो बोल रहा है प्लास्टिक करो फिर bypass करो, नहीं कर पाएंगे ना.
क्यों?
Occlusion का इफेक्ट जाता है, फ्लो कम हो जाता है, थ्रोम्बोस हो जाएगा.
रिपेयरिंग क्यों इफेक्ट जाएगा? रिपेयरिंग लोड का
नहीं, डिस्टेंस सर्टिफिकेट
प्लास्टिक
एक
है ना, तो वो एरिया
वैसे भी plastic here you have gone through the.
No, you can open up popliteal as well. You can do POBA in popliteal.
Again, that we plastered the whole popliteal as well as.
No, that was you should have done in the previous go, na.
So it was already 24 November, na?
ये वो तो आउटफ्लो नहीं था वो
नहीं आउटफ्लो ATA को भी किया था Sir, but we need to
decide everything, and anastomosis will be difficult. If you do plastic in that area, then anastomosis will be difficult if there is a flash and all.
No, see.
And there is always chance after bypass you can do plastic, then you can see what's going wrong.
No, my
This is
question
worst thing, but we didn't expect it that bad. But our plan was quite good.
इथे कुठे मला सांग इथे कुठे नाही वाटलं.
This was the anastomosis which
You did the anastomosis here ना? इथे केलंस ना?
थोडासा
and there was a lot of calcium during
No, my question is.
हां कदाचित ते पण झालं असेल.
So, why do you think what you are doing will have a different outcome? Because you have anyway blasted the distillery, you have blasted the popliteal, the SFA, everything you have blasted, correct? So, question is, how do you think, or what is the strategy to prevent this happening again? What is so magical about
Preemptively, what I thought,
her
HbA1c was 11.1 since last 1 year. And for that aggressive, I think diabetes control was made, and her lipid profile surprisingly was normal.
No, sir. After angioplasty, that bimper got opened up, and if you see, there is only vein graft is running faster than native artery, and there is a odd recoil. If you see post plaster, there is odd recoil, and it was done in 3 months
so my
back.
question is that your
And that's why
angioplasty.
atherectomy and all were advised, but she was not ready.
No, I understand. My question is, how will the outcome of the tibial angioplasty?
No, not tibial, SFA popliteal, the pulmonary.
You are on a bypass, right?
Sir, there was no other
Very serious. I understand. My strategy is that you have opened it up. Okay? And we assume that somebody opened it up 3 months ago. So now what do you hope to do different that graft, that angioplasty that you have done remains open? That's all I'm asking. I'm not saying you should not have done, don't get me wrong.
Then anticoagulation, full dose anticoagulation and controller diabetes, that's what we can do for
Full dose means what?
Warfarin.
Rivaroxaban 20 mg.
Sugar and warfarin. Or antibiotic.
What type?
Warfarin
20 mg means venous dose.
Or give a warfarin.
Warfarin is a PTI.
How much this works?
I will just try.
Is there anything else that you would have done in your assessment to help you? Or I did. Okay, let me rephrase it. Are there any other tests that you could do to find out if there are other factors which are responsible for this such rapid restenosis? Anything that you can think of in terms of strategy? Lipid side is normal. Anything else? I can see that her name is Patel. You check homocysteine levels?
Yeah, homocysteine is normal. Yeah. Homocysteine is definitely normal because previously also when she had done this angioplasty there it was normal homocysteine. I didn't repeat.
Anything else? Anything else?
Sir, does this high sensitive CRP matter?
Yes.
Matter?
So doing a CRP will help. Doing an anti-nuclear antibody. Because
but she
see,
was
I
male, female.
I got one lady who had multifocal disease like this. We did plasty and it was restenozing or somewhere else it was coming.
Distal vessel disease is quite severe. Distal vessel. Any diabetic. Yeah.
So probably you want to rule out other causes. That's
what else atherectomy was possible for SFA population because she just had
no, yours. I'm not criticizing or challenging your surgery. No, that is right. My question is how will you prevent something happening again in the next years? So that is my question. What is other things that you would like to think of and rule out or add on so that your result lasts for a longer time?
Now, if you have a native acid which is patent, if you have a native acid which is patent, and you have a graft,
Sir, this here after plastic.
तेरा क्वेश्चन जो है ना तेरा ग्राफ क्यों फ्लो ज्यादा हुआ बिकॉज यू हैव डन द प्लास्टी ऑफ पॉप्लिटल विद अ स्मॉल बलून
No. It was proper 3, 4, 5 and proximal SFA it was 6.
because we wanted to get
You
out of that
took a risk.
situation.
You took a risk. Flap should have मतलब ऐसा हो सकता था कि तुम्हारा ग्राफ proximal anastomosis में ग्राफ बंद हो जाता था. फ्लैप होके.
जेव्हा बायपास झाला ना, सो वी वर ऍटलीस्ट ये तो खोल देते जो नेटिव.
नहीं बराबर है, you are right. Got to be but the last film है that one.
Sir, after plastic, you can see the graft filling plus retrogradely your all this are filling femoral. So there is no question of amputating this thing. Which scene?
एक ऐसे डिसीज होतो एक ट्यूब बंद हुआ
डिस्टल फ्लो नहीं
Resistance.
Distal flow नहीं है.
पोस्ट प्लास्टिक सर पोस्ट प्लास्टिक
पोस्ट प्लास्टिक हाँ
The first DSA right वाला ये वाला जो
देखना ये ऊपर बंद है ये फ्लो ज्यादा अच्छा है यू आर राइट
क्लैंप हुआ हो गया होगा।
वो इतना कैल्शियम क्लैंप करना है.
ये तो अच्छा है
नहीं वापस
It is possible only there are 2% is possible for it is.
नहीं but at that particular moment you will find the graph getting blocked composed because of nightmare नहीं अच्छा है good
नहीं ये रन वापस करना.
So how many days post-op now?
2 weeks, 3 weeks. We remove sutures also. But that persistent first and second to those are
Okay, a lot of distal vessel disease.
you can always repeat the biomechanics within 3 weeks you can again repeat
Sir, in the hospital I repeated third time, but she got stopped.
सर कितना डायलेट करता है वेजो डायलेशन कितना.
all these patients को हेल्प होता है
नहीं,
What about the cardiac effect?
नहीं वो इवैल्यूएट करिए डू टुडे को मतलब 31% पे भी दिया है ऑल दिस पेशेंट और क्या करेगा
Arrhythmias होता है.
ये आई मीन आई सी टैकिकार्डिया होते हैं
हाँ, but on bioanalysis she was absolutely
very few well, one patient in 1 year can have hypertension बाकी प्रॉब्लम नहीं है
MI है उसका.
अभी एक पेशेंट
पेशेंट के लिए तो 100%
means that but you have to monitor ICU so what many then
अच्छा all days ICU or only one day?
all days
One more question in this.
ICU monitor कर
You have done the plasty and you have done all that. You have gone through the native vessel. So when you did the anastomosis and did this, could you have done the? I presume that you had put a sheath from the right side first, or you did it after your bypass.
My plan initially was to do a FEB ATA bypass, keep the groin incision slightly closed, go into the cath lab, open, puncture the graft, go through the graft, and do this. But we didn't have that time, and vein was of very narrow caliber, so we decided to come with
The vein will improve here. The vein size.
No, sir. On table it was very. It could have hardly taken any 6 days. It has dilated afterwards.
So this was
But,
GA or what was the anesthesia? GA.
Epidural, continuous epidural. Continuous.
फिल्म किसने दिया है
Epidural एक दिन पहले डाला था.
चिटचिट करते हैं
stop up करना है
stop up करें
So, next thing, to avoid all that, yes, we were in hurry because there were no distal signal. Foot was turning more risky, we punctured quadrilateral side, and then very deep.
What's that?
then was really
Use of hybrid we should have hybrid.
Siam you don't have on the OT.
Actually, I to send back to Gujarat, but they were not willing to send it.
Thank you.
हो गया चल लास्ट ही था.
I think that is the last case we have. I would request Dr. Amish Matre sir, Secretary Vasomac, to give the vote of thanks.
हो गया vote of thanks. Vote of thanks क्या?
we need to discuss few things
You are on camera. Please, vote of thanks.
welcome everyone this was thanks to Anirudh one of the first meeting for Vascular Club Mumbai. I think Pune guys are also trying to have similar meetings. We should have every month you should target, or at least bi-monthly you should target.
It's not the first, it's the revival. It's not the first.
I don't know Vasomac. I mean, not Mumbai club. Vasomac.
We are more.
नहीं It's a Vasomac first.
But it's a good beginning, I think.
It's a good beginning. And thank you everyone. Especially, that was a very interesting thing. Let's be more. I think थोड़ा aggressive करते हैं. Maybe bi-monthly we should do. Target bi-monthly at least. Bi-monthly, it's not difficult. Bi-monthly, 2 times. Not fortnightly. हाँ अपने मतलब जल्दी से bi-monthly तो it's supposed to be every 2 months. Every 2 months we should target.
Or alternate month. Make life easy.
Okay?
भावना बहुत है.
भावना बहुत है.
Sir, what else we should do post-operative to prevent progression or to avoid the progression? Right.